Unblinding could occur by accident or if a serious adverse event were to occur. All subjects were followed for 91 days. For the purpose of this trial, the follow-up was appropriate to assess short-term immunity. However, it would be beneficial to look at long-term efficacy of the vaccine. Appropriate statistical analysis was done. The full analysis set is equivalent to modified attention to treat. Because some data points were missing, this information was examined in 3 different ways, including multivariable imputation. The results had strong power as the results are presented with an overall 95% confidence interval.
The difference in seropositivity rates between the aerosolized and the subcutaneous group at a confidence level of 95% was negative 9.1 percentage points. This indicates that at statistically significant levels, the aerosolized vaccine was inferior to the subcutaneous counterpart. No deaths occurred during the trial. The most common adverse events were coryza, more common with the aerosolized vaccine, and crying, which was more common with the subcutaneous vaccine. Results of the secondary endpoints did not show non-inferiority either. The subcutaneous vaccine still proved superior over the aerosolized version. Special analysis was done on the missing data to determine seropositivity. Once determined, samples from all participants were analyzed again. Results from this analysis still remain inconclusive about the efficacy of the aerosolized vaccine. The results are presented in a neutral tone. Baseline characteristics of all the participants were similar, which provides validity when doing analysis. A full analysis was done on the per-protocol population for the primary outcome. The authors did report the numbers lost to follow-up and did a multiple imputation to determine the seropositivity of the missing data. The analysis was then repeated with inclusion of all the participant data. This type of analysis is equivalent to a modified intention to treat.
The discussion for this article did an adequate job of summarizing the main findings and clearly stated that the aerosolized measles vaccine was inferior to the subcutaneous vaccine in terms of serum antibody titers. It was also noted that the seropositivity for the subcutaneous vaccine group was consistent with published data. The authors also used the discussion to identify potential limitations of the study. The study limitations included loss of nearly 20% of serum samples during transit, a very young study population, and endpoints that were potentially too short. Although the study was rather unbiased, there were some potential sources of bias and confounding in the discussion. The authors focused on the positive results of one of the secondary endpoints, which could have been due to the confounding factor of natural boosting, which occurs in regions with high re-exposure to measles.
Another study we looked at was a randomized control trial done in Mexican school children to assess the immunity of a booster response of the aerosolized measles vaccine. After administration, seropositivity reached 100% for all participants, demonstrating that the measles vaccine can be used to achieve booster immunity in children. However, a large population of baseline immunity against measles is related to the high immunization coverage in Mexico, and only a small number of the participants observed increased baseline with the booster.
The study addressed an important problem regarding immunization against measles. Because the Western world has appropriate immunization coverage, the importance of this study is geared more towards less developed countries. However, recent outbreaks of measles in the Western world are not due to the efficacy of the vaccine, but rather a lack of education in the public. The study measured an important outcome, immunization against the measles disease via an alternative vaccination route. This will change pharmacy practice in areas of the world where measles outbreaks remain a problem.
Current literature for the initial vaccination states that it is not as effective as inducing immunity when compared to the injection vaccine. However, this does not mean the aerosolized version is completely non-immunogenic. A definitive answer to the efficacy of an aerosolized measles vaccine remains inconclusive.
Created using Powtoon.